In order to come to the answer of that, we first have to understand how morphology performs. And I like this study from Granberg that was published quite some time ago. But the reason I like the study is because Granberg used very simple notions of what's benign and what is suspicious. And he basically uses the same things that I use. So what Granberg found was that when he thought it was benign, he was virtually always right. Now, no one's going to be right 100% of the time in clinical practice, but you can be nearly always right. Where ultrasound falls down in the world of morphology is when we think it's malignant. That is where we are not very good. So here are the lesions that I consider to be almost certainly benign. Unilocular thin-walled cysts, less than 10 centimeters in a premenopausal woman, and unilocular thin-walled cysts less than 5 centimeters in a postmenopausal woman. So those two lesions are almost certainly benign. Hemorrhage into a unilocular cyst, almost certainly benign if it's a neoplasm. Extremely high percent will be non-neoplastic and disappear. Old blood in a unilocular cyst or one with 1 or 2 thin septations, we suspect this to be an endometrioma, and we will nearly always be right. Any relatively thin-walled cyst with 1 or 2 thin septations. So I will go up to 3 thin septations and call it benign. Any mass containing high amplitude regional echoes that cast an acoustic shadow. So these are all things we've talked about. That's my list. If it's on that list, I think it's benign, and I will be right. Not always, but nearly always. Okay, so here's a lesion. I found it. I see that it is a unilocular cyst, so I'm thinking this is benign. Here's the question. Would a Doppler change your mind? The answer to that question should be an unambiguous no way. We are starting with a positive predictive value that is 98.5%. To improve on that positive predictive value, the second level test, i.e. the resistive index, would need to be so extraordinary that literally we wouldn't have done the first test. We would have literally said, don't take a picture of it, just record a resistive index and write the number on a piece of paper, put it on my desk. Clearly not a chance. Now, we are now going to look at a paper from a man named Cummings. Cummings is a pathologist. So what he's reporting on is 861 ovarian neoplasms that were examined after sonography became a popular way of examining ovarian masses and finding them. What you can see is that 75% of ovarian neoplasms actually occur in premenopausal women. Only 25% occur in postmenopausal women. So why is it that we worry so much about postmenopausal women? And here's the answer. Because if a postmenopausal woman has an ovarian neoplasm, more than half of the time it's malignant. So her a priori risk is already greater than 50-50 if we find a neoplasm in her ovary. Now, Cummings found that 75% of the lesions were benign, 21% were malignant, and 4% were these borderline low malignancy potential lesions. Now remember that these didn't occur. There wasn't a category of low malignancy potential in the era of Carpenter's study. So for my money, you can take 2 of them and put them there, and 2 of those and put them there, and you end up with exactly the same numbers that were in the Carpenter study. So importantly, ovarian cancer isn't becoming more prevalent. What it has done is moved up the lethality ladder. So when I was a medical student, cervical cancer was the gynecologic lesion that resulted in death of most women with gynecologic cancer. Now, that is clearly not the case. Endometrial cancer was next, but that is clearly not the case. Breast cancer was next. Now, that is clearly not the case. We haven't cured breast cancer or made the same kind of inroads we have with cervical cancer, but we've done a pretty darn good job on breast cancer of late. But ovarian cancer, our therapies have not been that successful. So ovarian cancer has moved up the lethality ladder, not the prevalence ladder. Okay, again, if I hand you that textbook of gynecologic pathology, you have to be impressed by the large number of histologic types of benign ovarian neoplasms. But what I'm trying to get across to you today is that a minority of histologic types comprise the vast majority of benign ovarian clinical mass lesions that we will encounter. Here is the list from Koenig. 645 benign ovarian neoplasms. That's a whopping big number of benign ovarian neoplasms. I seriously doubt that I've seen that many ovarian neoplasms in my entire career. Here's the important thing. Cystic teratoma and cystadenoma comprise 95% of every lesion surgically excised from the patient's ovary that was a neoplasm. Far and away the most common is cystic teratoma. Of those 58%, 75% of those are characteristic on sonograms. Among serous cystadenomas, they are all either unilocular or oligoseptate, so we're going to get all of those right. Now, here is the list of malignant ovarian neoplasms. And you can say, well, what do those look like? Well, they look like a lot of different things, but that's not the point. The point is, how likely is it that any one of those is going to look like one of those? And the answer is, it is extremely unlikely. Our problem is this guy, mucinous cystadenoma, which looks very much like those guys. So our problem is not calling lesions benign. Our problem is calling benign lesions malignant. Now, mucinous cystadenomas are characterized by lots of echoes within them. They also have another hallmark, and that is that the echogenicity of the various locules tends to vary. Also, the mucin will precipitate to the bottom of the mass and create this so-called snowboarding sign. Nonetheless, with a multiseptate lesion, it would be difficult to say benign. These are benign solid tumors, and they're going to look very much like these tumors.